Hi, this is Dr. Kevin Winthrop coming to you live virtually from Portland, Oregon. You might wonder why I'm all dressed up. I'm going to an election party. It's been 5 days now. I'm still at the same party. I need to go home. Hey, I just wanted to say a few things that I found today that were interesting. Jack asked me to just throw in my 2 cents on a few things. I spent my morning in clinic, but before clinic, I woke up early and hit the poster session at 0600 PST. A couple things caught my mind, a few things that I was involved in, a few things that were presented by others. Abstract 215, Ernest Choi, caught my attention right away because it was a nice in-depth analysis of the issue of venous thromboembolism, or VTE, in the setting of JAK inhibition, and this time focused on the UPA data, upadacitinib. It was nice they were able to model risk factors for VTE in the program, and not surprisingly, they found what we found in other programs is that the single biggest risk factor is a history of VTE. And clearly, patients who have a history of VTE are at much higher risk if they're put on a JAK inhibitor to have another one, as opposed to those who have no history of VTE. So this is not necessarily a surprise. I do think it's something that can be used, of course, to guide management. I'm not sure I would choose a JAK inhibitor in someone who has a history of VTE. Other things interesting in that analysis, in the multivariate analysis, they did not find COX-2 inhibitors to be associated with VTE. Now, if you remember back to the Berry data, when that was modeled and presented, that was a surprising finding that in addition to a history of VTE, that another significant risk factor that was independent was use of COX-2 inhibitors. And that was hard to explain. I wasn't sure why that was the case. But interesting in this data, that was not seen. Other things noted in the data, there was some quirky associations with one of the dosing groups, UPA. I think the lower dose, actually, there was a statistical association with statin use. Again, that's hard to explain. I'm not sure. That's probably some sort of confounding or a fluke in the data. But overall, I thought what I took home from this was, again, that history of DVT and age. And of course, that's a risk factor as well. So if you look at some of the other JAK inhibitor data presented this morning, and there's a bunch of integrated safety assessments presented. I was involved in several of those. I'm going to get to that in a later little 3-minute blurb here. But just to contrast, I also presented this information in poster 229 in the same session. And this was in the filgotinib LTE data up to 5.5 years of exposure history. And I'll get into that in the infection stuff later. But the VTE stuff was interesting there. Now, the risk factors weren't modeled. There's really just not enough events to model. And that's really true of the UPA data, too. There's not a lot of statistical power because there's not a lot of events. But the rates in Filgo were around 0.2 for the 200 milligram group. And I think for UPA, the rate was also quite low and was quite stable through time. So I look forward to the real world. I think that's where the issue of VTE is really going to be better understood. Interesting real world data published recently by Phil Meese in ARD looking at corona data. Didn't really see any increased risk of VTE with tofacitinib starters as compared to those starting TNF blockers. And the rates were around 0.2 per 100 patient years, if I remember right. So I think we have a lot more to learn about VTE. I think it's probably a risk factor. Maybe it's just a risk factor at really high doses, particularly in people who have risk factors for VTE. So I think stay tuned while this gets figured out the next few years. So for Jack Cush and Room Now, I'd say go back to watching Room Now tonight after the conference, before the conference tomorrow, and enjoy your virtual ACR. Cheers.